applications. You can do uninostril, you can do binostril. Binostril, the advantage that you can have forehand technique, which is definitely going to be helpful, and it becomes a much comfortable surgery. Certain things you must remember. You must pack the nose so that nothing trickles inside the throat, and the BP must be kept low. I keep it 90 systolic, and then of course irrigate the nasal cavity with betadine, and then pack the nose with adrenaline pack so that the mucosa is devascularized. Positioning is very must be at the level of your waist. That's what I feel is comfortable. And of course, you position your equipment accordingly. The nurse must be sitting on your left side, or with the trolley on the left side, assistant opposite to you. So first step is the entry into the nose, where so you're in the nasal stage, you're inspecting. So you see, we enter and you see how the bulky turbinate is coming on your way. You, with a gentle dissector, you see this is devascularized with the adrenaline pack, so there's hardly any ooze or bleed there. And here, as you see, you can see in this particular case, there's a bony spur, which is coming in the way. So you have to know how to tackle these situations. You have to also know how to tackle a deviated nasal septum, which is going to be there in many of the cases. And then this second step is how to locate the sphenoid ostium. This is very important. You have to understand the sphenoid ostium is visible in 80% of the cases. In 20% of the cases, the sphenoid ostium might not be visible. There might be just small bleb of air or something there in the sphenoid ostium. So technically what we do, we go to the posterior nares, the nasopharynx. From there you climb up 1.5 centimeters. And if you just dissect this area gently, you'll find the sphenoid ostium which is sitting there. So here in this case, as I see, I'm struggling to get to the sphenoid ostium. But gradually, if you dissect through, you'll reach the sphenoid ostium and see the sphenoid ostium. So once you have decided where the sphenoid ostium, this is the sphenoid ostium beautifully seen in the same case, you have to widen this recess, the sphenoid monthal recess, because that's the area through which you are going to enter into the sphenoid sinus. And once you get into the sphenoid ostium, then you start your actual entry into the cella. So first is inspection, then is location of the sphenoid ostia, and now you are supposed to enter the cella. How are you going to enter the cella? So what you do is that you first dissect the mucosa on the septum, bony septum, and then you separate the mucosa from the bony septum and gradually deviate the bony septum to the opposite side and dissect the mucosa on both the sides. So this will lead you to what is called the rostrum of the sphenoid bone, and this is going to be the first step which you have to do. This is I'm showing a uninostril approach. If you have a binostril approach, of course, you have a second hand to help you also out. So once you have exposed this sphenoid ostium, you will see the keel of the vomer. So once you dissect the mucosa, you have now exposed the keel of the vomer. Once you expose the keel of the vomer, battery is running low, sorry. Once you expose the keel of the vomer, yeah, so here you see the mucosa on both the sides of the bony septum has been dissected out. You are now approaching the keel of the vomer, and the keel of the vomer is now visible in front of you. And this is, so I'm giving on the cadaveric as well as so this is the cadaveric view. Now in this situation, you see there are two, this is the sphenoid ostia on both the sides, and this is the keel of the vomer, and now you see the owl eye appearance. So that is the next thing you have to achieve. Once you have achieved the owl eye appearance, that means you have dissected enough to expose the sphenoid sinus and get into the sphenoid sinus. You then now drill or cut all around the keel of the vomer inferiorly so that you can easily remove it. And then you have to enter into the sphenoid sinus. So again, sorry. So you use what is called a lux forceps to remove the posterior part of the nasal septum, and then you use the same lux forceps to remove the keel of the vomer, which you can do very easily. Sometimes you can even use just a needle holder, which is strong enough to remove this bone. And now you sort of get into the sphenoid sinus where you can see the sphenoid mucosa. Ideally, the sphenoid mucosa should be removed because in the post-op period, if you have to pack with fat, you can have mucocele formation. So ideally, if you remove the sphenoid mucosa, this is where I'm removing the sphenoid mucosa. And now you see there is a septum of the sphenoid. They will get a septum of the sphenoid sinus. The sphenoid sinus septum in 70% of the cases is not in the midline. So it's natural to see that it's off the midline. Then you can have one sphenoid septum in 75% of the cases and about two sphenoid septum in 20% of the cases. And you can have three also sometimes. So this is again a nature's anomaly which you see. So this is the cadaveric identification which you'll see in the cadaver today. You have got the carotid prominence on the top. You have to see the optic prominence on the top, then the carotid prominence, upper carotid prominence, lower carotid prominence, the clival recess, and the sella. So this is depicted in the live situation. So that was cadaveric. You have the optic prominences, the carotid prominences, the sella, the tuberculum sella, the plenum, and the clival recess. So all this is going to be in one plane. When there's a lesion, the sella gets expanded, and sometimes you might not find a very clear depiction of all these things because the lesion expands and sort of drives away all the anatomical structures around. So once you have got into the sella, you need to have the axis, and you have to increase the axis, so you can use an upcut Carrison punch. You can also remove the sphenoid sinus, the ethmoid sinus in the front to have more access, more space. And then after that, as you widen, when you're sure that there's enough space to enter into the lesion by coagulating the dura, so you're now coagulating the dura here, and now you can enter the lesion. How to open the dura? There are various techniques. The first thing you must remember is that if it's a large lesion, don't plunge anteriorly. So better you make a horizontal cut the lower part of the dura, remove as much as possible from below, and then the posterior part of the tumor, and then let the anterior part and the superior part then fall in your field. Otherwise, if you go at the front, what is going to happen? The diaphragm will fall, and in that case, you'll have a problem in reaching the posterior part of the tumor. So that's not to be done. You must remember that. And then, of course, once you have coagulated the dura, you are going to be in the lesion. And in this particular situation, as you see, that the lesion is coming into view. So this is partly eroded, actually, the dura. So this lesion is now, there was some hematoma in that lesion, so that just came out. So this is how you are now gradually with a ring curate, you're removing the lesion. And then this lesion is gradually getting removed. You can use a Ronger, you can use curate. So I'm tackling the posterior part of the lesion so that, the anterior part falls gradually in my field and the upper part then comes last. So that is what is happening. So as I go deeper and deeper, I use the scope. And now you see the diaphragm is falling. So I've dissected the posterior part, then the anterior part, and now the diaphragm with the remaining tags of the tumor on the diaphragm is coming into my view, and I'm trying to gradually suck them out. You can use a 30-degree scope at this stage to enter the sides and see whether there's any remnant of the tumor which is there. And so this is, as you see, very nicely coming out. Be careful not to be too vigorous in your suction, otherwise you'll rupture the diaphragm and sella, and then, of course, there will be CSF leak, and that would sort of spoil your surgical endeavor. So this is what is happening. I think, yeah. So at the end of the day, you have a view like this when all the lesion is removed. Whatever you can see has been taken care of. And now there's a diaphragm which is bulging nicely. Now the problem here is that when the diaphragm is bulging too much, in the post-op period you can have prolapse of the optic nerve, and then can be another problem. So you have to buttress that. We use flow seal to stop the hemostasis and buttress that little bit of fat, which you take from anywhere in the body you want. I take it from the abdomen, periumbilical region, so that you don't have the complication of prolapse of the optic nerve in your field. So repair, you can use first flow seal, fibrillar, then small piece of bone, and then some fat. And then, of course, you can have pack both uninostril or binostril, depending on if you have used both the nose. I'm coming to the end of my talk. What about the learning curve? Yes, there is a learning curve in this. So you must sort of, first graduate through microscope. I insist again, please don't venture into endoscopy first, because a microscopy is a must. That will help you as a backup plan if anything goes wrong. And that's a must for you. At least do 50 microscopy. The problem is nowadays that very few people are doing microscopy. So I don't know how are you going to pick up. So that's the issue. Yeah, everybody's starting endoscope. Yeah. So at the end of the day, I get patients where people have been able to remove the half or one third, and then they come to me what to do next. I do the microscopy then. So that's, it goes the other way around. So that's something which is not acceptable. And in the future, of course, you are going to use robotics and other things. Thank you. Thank you very much. Yeah.
Now, Dr. Pathak sir will start with the cadaver dissection. How to enter cellar with the Professor Shankla. Both will show. Those who are interested in endoscopic endonasal can stay here, and we are going to start at the same time the spinal at the back, because our program is too long. It will not be finished, and you will not get time to have the hands-on practice. So those who are interested in spine can go back. We are starting there. Dr. Dattaraj and Dr. Jayesh Sardhara will start at the spine, at the back. And here Dr. Pathak and Sankla sir will start. Yes. Yes, sir. सर ये यहाँ पे लगवा दो सर यहाँ पे सर कितने लोग हैं नहीं अभी आप डेमोस्ट्रेट करो ना हाँ उस पे आएगा अच्छा उसको मुझे वो दो ना अरे कॉलर माइक दे दे बेटा नहीं कॉलर माइक का काउंट डाउन दो कुछ डाउन हाँ एक पहले तो ना इसको ऊपर कपड़े बंद हो जाएगा मैं तो यहाँ रहूँगा जो ये डिसेक्ट करेंगे वो यहाँ तुम थोड़ा पीछे ले लो बस सब ठीक ईयरफोन नहीं है क्या माइक्रोफोन Dr. Likhit Talkhandi from Glasgow, and here Dr. Sankla sir and Dr. Pathak sir will show the how to enter Sela. Then after that, Dr. Vasundhara, where is Vasundhara? She will show us the and then extended approaches and all. Amol Raheja later on. माइक दे दो ना यार सर को वन माइक है हाँ ये ले जाओ ना उधर उधर का मैं बुलवाता हूँ कुछ मैं करवाता हूँ आशीष कहाँ है आशीष कहाँ है
When I do this CPN and ventricular endoscopy, is there a separate head for that?
No, these are the only patients. You can do it, show it in here.
I know, but when do you want us to do the craniotomy I'm planning? Because it's better to prepare before I go.
So you can prepare in this patient. In this, you can
You
prepare.
have drill and everything?
Yeah, we will give it. Drill is there.
Perfect, okay.
Yes, a scope is there.
Perfect, okay.
Yes.
We have endoscopes, scalpels.
वर्कशॉप के लिए सर रजिस्ट्रेशन हम लोग का नहीं होता है क्यों?
आ जाओ मैं कराता हूँ. अरे बेटा सर को हेल्प कर दो इधर ये इसमें अरे आशीष का है आशीष ये बेटा इनका तीनों का रजिस्ट्रेशन नहीं हुआ कर दो अभी कुछ कंफ्यूजन हुआ है देखो क्या है जा बेटा करो
सेवलॉन और गॉज पीस के लिए किसको पकड़ूं?
सेवलॉन रशिम कटारिया
सारी सात दिन पर संपेल माइक मिलेगा?
हाँ वही बुला रहा हूँ मैंने बोला उसको यस सर
यहाँ पे
इसका हेड को नहीं सर ये तो देखो कैडेवर में स्टिफ हो जाता है ये नहीं घुमा सकता इसको तो आप पूरा ऐसे घुमा सकते सर
Yes, sir.
कल्याण फ्रॉम हैदराबाद सर अच्छा किया सर
है ना जयेश है वहाँ पे और दत्ता है अभी लिखित चालू है एक तो कॉमन माइक मेरे को दे दो ये वाला माइक इधर से कनेक्टेड है एक माइक उधर चाहिए ना
उधर तो आवाज़ अलग से नहीं आएगी ना
नहीं उधर के लिए छोटा सा रख दो कुछ भी चलो ठीक है क्लास
सर अभी 5 मिनट में आ रहा है बुल्लर के बोल रहे हैं अभी आ रहा था आप बीच में उधर भी फोटो ले लेना उधर अलग क्लास चल रही है ना वो लड़के लेके आ रहे हैं कौन लेके आ रहे निकल तो गया क्या ये हैंड माइक लीजिए जब तक चलो वो आर तुम्हारा हेडफोन लगा दो
वो लगा रहे हैं सर और बाकी आपका सर आप इसको बोल सकते
या नहीं यहाँ खड़ा तुम यहाँ ठीक है ना चलो let us start this transcellular approach first. You can hear me, all of you? Yeah. For that you need to have a patent nasal cavity. So here, you know, a lot of things have been pushed into the nasal cavity, so we don't know right now. Right now what we have done is made the position very suitable for this approach. Okay, now we'll take the endoscope and then go into and then see the nasal cavity and see if everything is okay. As usual, you know, these are the, you know, very stiff kind of bodies because the cadaveric dissection. So there will be some limitations, but we'll see how things go. Have you got a suction?
Check, check. Hello, hello. Check one. Check, check. Hello, hello. Hello. ले सर के लगा.
सुनील सुनील वो देखना पड़ेगा हमको. इधर 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 इधर. हाँ ठीक है अब ठीक है. I think it should be okay. How will you will have to put something inside underneath this.
Hello,
है तो
hello.
रखो, otherwise
Hello.
it's all right. Yeah. Now looks stable.
Hello. Yeah, okay, thank you. So now we are starting the dissection. The neck of this patient was turned to one side and it was stiff. So that's the reason we had to turn the patient. And now normally I enter to the right side, but it doesn't matter. I'll enter. Suction देना.
Slightly more turn bus. That's fine. That's fine. No, no, no. I think that is okay. You know, then it will become unstable.
Suction चाहिए. Suction नहीं है. Okay. Suction nozzle तो है. We need a suction. Okay.
Just put the endoscope in. Let's see.
Yeah, we are putting the endoscope in, and the first thing, as I said, we inspect the nasal cavity. And as you can see, as you enter the nasal cavity, you can see the turbinates and the nasal septum on your left. I need a suction to clean all that fluid which is there. And the first thing you go is to, as I said, you create some space so that you can maneuver your scope into the depth. And then the next step will be to reach the nasopharynx. Once you reach the nasopharynx, then you dissect up to go 1.5 centimeter. There is some debris here, which unless I clean, I can't show you better. And then you reach, find this phenard ostium. So I'm waiting for a suction to operate. Okay. Okay.
This is a 0 degree and very rigid endoscope, so it gives you the straight vision of the nasal cavity.
ये लगेगा इसके साथ? Right. While we are waiting for the suction,
I will call somebody.
Yeah, I think
mm,
somebody from SMS should be there.
suction तो होना चाहिए. Suction, without suction you can't do anything much. There's no suction,
Suction.
and the nose is full of all muck.
Problem is the connection.
Problem is connection. Suresh, I mean, Prakash, its problem is
You know, between this
this the connection between this and this.
some tube is required.
Rashim, ये
Another length suction.
अभी इसके साथ इसका मैच नहीं हो रहा है.
We are also struggling over there.
ये
ये नहीं है suction tube.
के सेक्शन किसका है?
सेक्शन तो हमने खरीद के लाए हैं सर, ये वैसे पर पता नहीं ट्यूबिंग क्यों नहीं है
नहीं,
इसके
इनका
साथ.
कोई आदमी नहीं है क्या? या फिर उसको मालूम होगा सर. You are neurosurgeon or you also? Anybody from ENT? Not that you.
ENT people entered.
Lose it.
इसको शीत लगा दो, नहीं तो खराब हो जाएगा तुम्हारा. टेप माइक्रोफोन का ओटी थोड़ा है तुम्हारा, माइक्रोफोन लेके घूम रहे हैं. अच्छा टेप, हाँ वो टेप है, वो टेप थोड़ा लगा के देखो. वो देखो.
इसको पहले चालू करके देख लेना पहले.
अच्छा पहले चालू करके देखो.
चालू करके देख लेना सर पहले.
हाँ, that's really good.
Connection problem.
Well done, well done. हाँ, जुगाड़. On.
आवाज आ रही है ना? मशीन चलने की आवाज.
Yeah. Okay. Right.
We are starting now.
Right. Okay. So as I said, इसको पकड़ना. So first we inspect the nose, and as you inspect the nose, you can see we're entering. Now there's a way to hold the endoscope. This is going to be 12 o'clock position. So always remember, if you tilt this, your images will be all tilted also, so you'll go into the wrong direction. So always hold it like this, with 2 fingers like this, and 2 fingers here, so that the 12 o'clock position is not, changed. And then only you have the proper orientation. So as you enter, you see the inferior terminate, and then gradually with the suction, in this particular case, there's so much of fluid inside. suction is not working. It was working earlier. The problem is the suction gets blocked, you know. Within. It might be working, but I think something has blocked it. Anyway, let me see. There's all fluid inside. Yeah, look at all this fluid.
It's not working.
It's again blocked. Probably it's blocked. So और है सक्शन है इसको तो फ्लश करना पड़ेगा
थोड़ा बड़ा बड़ा सेक्शन है बड़े बोर का
प्रेशर भी कम आ रहा है आई थिंक प्रॉब्लम यहाँ से ओ ये ओपन है ना सर ये तो सारा एयर यहाँ से निकल रहा है
Okay.
that thing is open yes
this is only not connected
इस पे नहीं है
there is no pressure here पहले आ रहा था इसमें नहीं होता डायरेक्टली करना पहले तो ऑन था प्रेशर तो
देखो ना वहाँ पर वो कांटा नहीं जा रहा है एक मिनट
इसको थोड़ा और पास में ले लो नहीं तो ट्यूबिंग खींचेगा इसका
या पहले तो देखते हैं चल रहा है कि नहीं कहाँ चल हाँ ओके ओके नाउ लेट अस सी वो जो ट्यूबिंग कहाँ गया पहले वाला ये पहले वाला ट्यूबिंग है yeah I need to have something to stabilize this connection here the same jugaad system same tape okay इसके ऊपर लगा दो so that yeah, we keep it like that. Okay. Chalo ji, let's hope now this works. If you please hold it for me. Thank you very much. So again, as you see, on my left is the nasal septum. On my right are the turbinates because we are entering through the left nostril. So I first go and suck out all the debris here, which so now as you see, as I go down, I'm removing this turbinate on my right and I'm entering below the middle turbinate. I'm entering into the, as you see everything is stiff here in a cadaver. So that's something you must remember. It's different from normal body. This is the middle turbinate as you see. I have to lateralize this and at the same time Have they got some Savlon? They don't have. So can I have a dissector? So next time you run a workshop, remember these things. These are the small problems which. हाँ तो ये फिर next time ना अपने पहले इंश्योर करना इनको बता देना ऑर्गेनाइजर्स को that we'll need these things. So I'm lateralizing the turbinate basically to create some more space. Now the problem in the cadaver is that this is all stiff. So in the normal body they're all malleable, they are soft, you can easily remove them, but here everything is hard, stiff, and that's the problem. So you first go to the posterior nares. So I'm trying to find my way through the stiff tissue here to reach the nasopharynx, which is the entry through the posterior nares. So this is again 12 o'clock. There you go, there you go, there you go. Now this is something which is coming in my way. Go, 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 go.
It's all very stiff and it's very difficult to find the proper canal through which you can go into the whole nasal canal, and at the end you can find the ostium. The whole goal is to find the ostium and then
Yeah, there's some
expand
more
it there.
fluid here, as you can see. Do the mucosa falling in your field? Very stiff tissue here.
Suction, sir. Give me. Suction has come.
Yeah, thank you. That would be great.
Better suction, yes.
A dissector motor. I need a thicker, stronger dissector. Something hard or strong. The other option is इसको dissector. I use it. हाँ थोड़ा सा some stiff hard dissector which I can push the tissues.
Take
This
this one.
is a very narrow, na, so it's not allowing me to create some space. So I have to become crude here. Let me see what I've done. So I'm just trying to create a space which is to allow me to enter into the. First thing is go inspect and go to the posterior nares, which I'm trying hard, but because of the stiff tissue here, it's going to be a little bit of struggle. There's some fluid there in the bottom. Suction, please. Thank you.
Yes. This may be. So.
So I'm trying to create space because this is a stiff body here. इसको जगह को बड़ा कैसे करना है स्टिफ टिश्यू है ना नथिंग इज टिश्यू pliable it's not pliable let me see through the other nose yeah suction please So this is the nasopharynx which I've reached. This is blocked. I think now the suction is not working.
The suction is not working. Yeah. Flush, you'll have to flush it.
ये bottle, bring the bottle here, open the bottle.
अब मेरे को बताते रहना तुम ना
Something is sticking to the tip. जुगाड़ करो Okay, now with a lot of struggle in the stiff tissue, we have entered the nasopharynx, the posterior nares. Okay, now we have entered the posterior nares because there was stiff tissue here, everything was, now you go, you come up. So now you have to get to the sphenoid ostium and find where the sphenoid ostium is. नहीं मुझे चलो जो भी है हाँ काम हो जाए बस हाँ so now this is the junction of the septum on the right side now I've entered in the through the right nostril septum is on my right and the sphenoethmoidal recess is on my left so this is we have to now gradually go up and see whether we can see the sphenoid ostium.
Maybe this one, yeah.
Yeah. So from here, you gradually go up.
There you see the fluid is coming.
Dissect it to me, please. So you lateralize everything. This.
Yeah.
Yeah, I think last thing we have to do is to take this cabinet out.
First we
But that's not.
identify
I was
structures,
trying to do the
and then if necessary we can-
conventional thing, but I don't want to do something unconventional. Normally, we never need to remove the middle cabinet to do this. But that's a shame that. So here, for the sake of creating more space, I'm taking the middle cabinet out. Yeah, that section is too thick, perhaps. ये थोड़ा मोटा हो जाएगा.
This one is good. ठीक है.
So, as Dr. Rijunitha, one of the professors in ENT is suggesting that we take the middle cabinet out. So, with her kind permission, we can take that out.
Yeah, yeah.
But I would take this. Yeah. But I'll take this out from here itself.
Attachment.
Yeah. I'll ऐसे ही निकाल देता हूँ मैं कई बार निकाला मैंने so here just remove it like this
This is good.
No, here we are doing to create space. Normally we never do a middle terminectomy for simply entering the sella. So this is I am doing something totally unconventional. Let me confess that.
To avoid this thing, you should not remove it completely. You should leave a leaf,
Yeah.
small shelf of this thing, yeah.
Yeah.
And then you cut it and then gently pull it down, gently. It will come. Then cut it. Pull it down, cut it. That technique. Yeah. No. If you try and clean it off completely from the roof, then sensory impairment as well.
I would even for a 4 centimeter
Olfaction.
adenoma, I would still not remove anything. Yeah. 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 Yeah.
And here, when we are showing the anatomy, after showing all this thing, you should remove it.
So this little bit of butchery happening now. Can't help it. इसको साफ करना है. कॉटन मत यूज करो. कॉटन से तो एंडोस्कोप क्लीन करेंगे ना. Yeah. Suction. Cotton, please. Cotton again. थोड़ा इसको भी निकाल देता हूँ. Then I'll have more space.
ये पूरा निकाल दो ये वाला.
Yeah, I'll remove all that. Can I just have this bigger suction? That would work better. If you hold this for a moment, please. Yeah. Okay. Dissector. I still have difficulty in reaching. I showed you the posterior nares, but the tissue is so stiff here. That's the nasopharynx. From here you start going up and then lateralize the attachment here. We go up. Yeah.
It looks like.
Yeah, but the question is, question is, it is so stiff tissue here, nothing is malleable.
So it is.
So the os would be somewhere here. You have to imagine, I'm afraid this cadaver is not allowing me to give enough access to that area in a very clean manner. So I don't want to waste huge amount of time because the trainees have to do. So what I will do is that I'll make a opening in the mucosa here on of the nasal septum, and then expose the bony septum and reach the keel of the vomer. So that's what I want to do. Have you got a sickle knife or something like that?
Adult slab also.
Yeah. Ideally, in this situation, if you're planning to do an extended end.
At least we are demonstrating
Yeah.
an outline,
Yeah.
where exactly
Yeah.
will be. Yes.
So basically, if you want to do an extended approach, where you need to ultimately make a big hole and seal that, we need what is called a Haddad flat. And it starts from it's based on the sphenopalatine artery, which supplies the Haddad flap. So you make a horizontal incision from the base of the middle turbinate level, and then you sort of on the septum, on the septum of the nose, and then bring it down right at the mucocutaneous junction, and then go down, go to the right base. You can go across the base, and then go back. And then once you raise this mucoperiosteal flap, which is a very vascular flap and very good sort of buttressing the defect that you have got. That you then turn with the pedicle of the spinopedal artery down into the posterior nares, and then that's where you get a Hadad flap. I'll make an opening straight over here without going too much deep because I'm not able to do anything. So I'm making an incision in the mucosa here to expose the bony septum.
You see that that part. This is the bony septum, and then this.
So
the
this is the
mucosa
bony
above it.
septum. So I'm making an incision slightly anterior because I'm not having a good entry at the back. So this is the septum of the nose, and which is denuded of the mucosa. Can I have a dissector now? Yeah. So वो पहले if there's a deviated nasal septum, I use the nasal speculum and try to correct it first, and then I make the incision, because otherwise, that becomes a difficult situation. So this is the mucosa. Keep dissecting the mucosa, keep dissecting mucosa. This patient actually has got a deviated nasal septum. This bony septum is going to lead you to the keel of the vomer. So what I'll do here, I'll break through the bony septum and go to the other side. So this is the bony septum, sorry. So I've dissected the bony septum and going to the other side. So remove this part of the bony septum. Give me a forceps to remove this bony septum. This is, there was something smaller, I think. That's better. It's like a teleankle forceps. So some of the bony septum has been removed now.
Sir, at this time, can we see before reaching there how to take Hadad flap?
That we have discussed, but
Okay.
the tissue is so stiff here, so there was. So now you can see the bony septum has been denuded of the mucosa. Sickle knife to me, please. Yeah, okay, I got it. I'm just making extended this incision to the lower part. Give me something to remove this anterior part of the mucosa. नहीं, मैंने सिर्फ ये जो overhanging Mm. इसको भी I'll remove this bit also so that I have better exposure. Right. So as clearing this tissue here, so that I can show you the keel of the wormer in a better way. तुम्हारा सेवलॉन आ गया नहीं आया अभी तक? Something sticking at the tip. Dissect it to me, please. So this is again peeling off the mucosa from the bony septum. So stick to the midline and follow the bony septum. So that is the mantra here. So you can see this is the bony septum. This is the bony septum. Can you see the bony septum? Yeah.
This is the keel area.
Yeah. So we are reaching the keel area, keel of the wormer. Yeah. Give me something to remove this overhanging mucosal flap. Does it hold? Does it hold? Give me something. This might be better. नहीं, इसका भी बंद नहीं होता ऐसे. They all used instruments which are not having good grip. ये तो angled हो गया ना? Straight चाहिए. Yeah. Normally we don't remove all this mucosa, but here for the sake of clarity, I am forced to do this sort of butchery, which is not warranted. You are supposed to preserve the mucosa because mucosa has got a very important role, not only in air conditioning of the air that enters, it also collects all the dust particles. So it's a gateway, into the respiratory passage. So this is something, rather I always denounce people removing too much of mucosa, and I'm myself doing the wrong thing here. Mucosa is very protective. Like a Hadad flap now coming out. Hadad flap came out.
Whole flap has come out.
The bone flap has come out. Anyway.
Anyway, it is
Yeah, so this is
more clear.
suction now, because to do all that, to clear all that area.
We take the Hadad flap on one side, no, for like craniopharyngioma, the large tumors.
That's what he did.
So, yeah.
Slightly shifted, but then it came out.
Mhm.
And the other side also we do the rescue flap.
Yes,
Don't destroy the
Yeah.
If necessary, you can always have the rescue flap.
that can be utilized in taking reverse Hadad also.
Reversal.
Yeah, reverse Hadad.
There are several ways of doing it.
The rescue can be turned over the floor of the septum. So whatever is left, that covers
Absolutely. Yeah.
posterior part of the bone septum.
Now that we are doing more of this surgery, more and more ways are known to us now. That's all right.
Right. Yeah, that's looking slightly better. Now can I have the dissector, please?
Go up to that.
Yeah, I have to go up. So this is the anterior wall of the sphenoid bone, and this is what is called the rostrum of the vomer bone. And you dissect the mucosa again, this stiff tissue here, not heeding to my dissection at all. Ronja, please let me remove that overhanging ledge of tissue. नहीं ये छोटा सा जो वो है ना इसको मैं हटाना चाहता हूँ right yeah so you see the two openings on two sides. Actually, because of my destructive surgery here, because I had to do, all sorts of butchery, to be very honest. You can see the rostrum and two openings on both the sides, which are actually the extension of the ostia and giving what is the owl's eye appearance, as I showed you on the screen, if you have noted. Now, the next thing is that you have to remove this. You can use a drill. You can use a lux forceps. If you have got a patient with acromegaly, the bone will be so thick that you have to use a drill. There's no way you can, the hard bone, sometimes it's very difficult to remove. Can I have something like lux forceps or telehankel? इससे हो जाएगा?
Once you expose this area, the rostrum and the keel and all that, then you have two very big advantages. One thing is that the
इससे एक बार मैं कोशिश, let me try with this.
and second thing, one of the ostia will come to
Yeah, two try.
So then you open the other or
So now I am removing this, as you can see. नहीं इससे हो जाएगा तुम्हारा अपकट एंड इससे हो जाएगा हाँ हाँ
anytime the safety inside the sphenoid cavity are so many that you end up first opening part of it, thinking that you have opened everything, but if you are not. So always look for the
yeah absolutely right absolutely. So now what you see is the mucosa in the sphenoid sinus. There's the mucosa of the mucous membrane which is lining the sphenoid sinus. So we have entered the cella, we'll enlarge this. And okay. So can I have a 2 mm upcutting? 2 mm upcut.
Normally you use drill, very nice drill, so that, it opens it up, ostium and meat goes to ostium, as well as you enlarge the cavity of the anterior wall of the stomach. Both are very helpful.
Mm. Down cut with give me the down cut.
They don't interact with the meat.
Yeah, I'll just finish it up now. एक बार I've entered backbite वाला देना.
Once you remove the stenoid mucous membrane, then the entire cavity is open to you.
अच्छा, yeah, I can rotate it.
And you identify the cellar flow, and that's it. Then at least the first step is over.
Every time we do a cadaveric workshop, and I swear that next time I won't do this sort of butchery. But then again, you feel. Ah.
But here you should know what you are cutting.
Give me standard upcut, standard upcut though. Because bone. I am expanding the floor of the cellar, and the floor of the sphenoid sinus.
The best cadavers we got were in the Sion hospital. They were not actually anatomical cadavers, anatomical body. This is the postmortem. So previous night head injury, that died. Next morning on the table. Next morning only. So it's like, bleeding. As fresh as bleeding. You should be in touch with the forensic. Because they are the ones who they hold this thing.
Suction.
Known people will have to take permission. They give, they don't give. But the cadavers you find, absolutely.
So there's some bone on this side also. This is the mucosa of the sphenoid sinus, as you can see, and you can see some bulge there. Can I have some forceps to remove this mucosa? Chota wala, patla wala. The small one should do. I think this one should be ideal.
We always take the ENT colleague with us at this level. He does it very fast and very good and very he also shows
Suction.
normal structures. Feel it. Absolutely. Like him, see how he made it. Yeah, Shish.
Yeah. Oh. The great man is there.
आएंगे डेलीगेट भी आएंगे
So, oh, morning. क्या बात है, बड़े लोग आ गए. So now what you see on your left side, can I have the ये cadaver is so stiff now. It's a big problem with this stiff cadaver. I want to show. So I'm just, after this I can start your dissection. Now we have entered the sphenoid sinus. So this is a sella, and on the left bulge that you see, हाँ कर दिया. It's 12 o'clock position. On the left bulge, on the left upper corner that you see is the optic prominence, and the bulge below that is the upper carotid prominence. Bulge below that is lower carotid prominence, and below that this is the clival recess. Okay. So I think you should start your dissection, and then carry on with that. अच्छी तरह दिख नहीं रहा है. But I don't want to waste time. Let them get to that. ये prominence दिख रहा है? You can see this prominence now. That's the sellar prominence. Yeah, and below that is the clivus there. Yes, the clival recess that you can see. Okay, so get on with your work, and then as you dissect, we'll show you the remaining steps, because now you have to drill this and go ahead, so you can do that thing yourself. So this, as you drill this, you'll get into the pituitary. But when there's a big tumor, the whole thing bulges out like that, so it becomes very easy. You can just with one tuck you and enter there. Yeah. It's eggshell. Sometimes even the tumor burrows through. You don't have to do anything much. उनको करने देते हैं because we'll waste time. Yeah. Okay, pleasure. It's very tough tissue. Pleasure. बाद में पता चला मेरा नेक रोटेट हो गया से. This 3D. Oh. हाँ ये हटा दो.
resection of the septum than you could traditionally do. Your middle turbinate remains the landmark. All that has been removed in this case for demonstration. Till middle turbinate, you can remove it safely without any much issue. So once you have adequate removal of your septum, you'll see the binostril approach really becomes more convenient. It opens up the field, and you can work around in a much precise manner. So this is a very important instrument. It's called backbiter. The punch, you can rotate at different angles and take out the septum. Sorry, can you just clean it? So you keep biting it till the time you feel there is adequate space. Ideally, it should be taken down all the way down because in most of the extended approaches, you want a superior to inferior angle, enough space. So you need to sometimes drill the base of the keel of the vomer and the rostrum to its right base, where you can see the clival recess. You can maneuver your instruments more precisely. Can I have the dissector first? Dissector. So this, ideally you should have a bigger dissector than this for the mucosal stage. This one is a little finer, which is more relevant for the cellular stage. So again, this is all the sphenoid mucosa. Once we remove the sphenoid mucosa, you'll be able to appreciate the bony anatomy in a much more precise manner. Biopsy straight. So you have to get rid of this mucosa. Sometimes it's inflamed in patients and you can send it for culture. Sheath nikal den. Yeah. Okay, clean please.
Should be pulled out.
Yeah.
You do all the bony work because otherwise
Absolutely.
bits of it comes out and bits of it left behind. You have to take hadar.
Yeah, and then there's more chance of mucocele formation if you, because ultimately the reconstruction of the skull base is as important as going in and removing the tumor or pathology. So unless you have all the mucosa removed, it can actually cause secondary infection in the patients.
Do your keel work and
Yes. So don't be in a rush to reach the tumor. Like you need to have adequate exposure. Can I have the backbiter, please? Okay. Upcut.
posterior superior septectomy.
Yeah.
Preserve the choina.
Okay, can I have backbiter again? Thank you. So again, you can see there's a bit of the septum which is coming in my way and causing fogging, causing disturbance in my view. So I have to remove that part too. Can you clean this? Sir, backbiter se ho raha hai. I'll take the sickle knife. Yeah. All right. So you need to take it down a little bit more. Like Dr. Ashish has said initially, that exposure is the key. Can I have a biopsy? Straight biopsy, this one, yeah. So once you remove this mucosa, you'll be able to appreciate the anatomy more precisely. I mean, you can rely on navigation in real life, but I think unless you understand the anatomy and know the basics about it, you'll always tend to go haywire around it. and you can compromise the safety, especially the relation with the carotids, the optic nerves. That is the key. Okay, can I have upcut? So now you can see the sella suction there, please. Thank you. So again, you use a binostril technique to reach and define your, so this is a claval recess, this is a sella, this is a superior part of the sella. You can see actually the anterior intercavernous well, and that's the LOCR, the optic nerve right there, the carotid bulge over here, and this is the medial opticocarotid recess right there. Sorry? Okay. So, I mean, you need to understand the anatomy well, and this is your planum sphenoid, tuberculum sellae, this is a planum. Yeah. And so you can see the septum, many times the septum goes towards the carotid. So you have to be very careful while drilling on that, or, so you should not use biopsy to pull it, either use upcut to trim it down, punch it down right close to the carotid, and drilling is actually good. So can we have the drill ready too? We'll require it shortly. Carotid, yeah, absolutely. Can I have upcut? And we'll use a downcut too, shortly. So wide sphenoidotomy is the key, especially if it's a NOS4 tumor going across pituitaries, giant pituitaries. Okay, just hold this. So we'll use the downcut just to trim down the base of the sphenoid a little bit more inferiorly, because unless you have an adequate working angle, you'll not be able to do the justice in your surgery. So extended endoscopic is actually a maximally invasive procedure. It's not a minimally invasive procedure, but you have to be thorough with the anatomy. Your landmarks have to be clearly defined. Working space has to be precisely tailored to the individual patient's requirement. Can we have the drill, please? Drill. Thank you. So this is a cutting drill. Yeah. Okay. No, it's okay. Okay. So suction. So again, the key is like Dr. Prakash is holding the scope at from 12 o'clock in the nostril, and my suction is going at 6 o'clock. So that is the key, so that there is less interaction between the thing. I think the nose is a bit stiff for 2 instruments at a time. Yeah. So we're getting the sheath back on, because sometimes the drill can get close to the endoscope, and that can compromise its integrity. So I'll take my suction along with his scope. Binostril too, yeah, absolutely. Okay, the drill foot pedal is, I think, hidden. Can we have the drill foot pedal out? Okay. So we'll use the drill just to trim down the base of the sphenoid sinus as low as possible. And you have to use a cutting drill at this stage, but you can use diamond when you're close to the carotids, the medial opticocarotid recess. So Dr. Prakash is doing an excellent job to show me the field of interest, and that's in the center of my operative field. And also midline orientation is the key, so that you don't go haywire during your exposure. Okay. All right, can you put some irrigation from here, from a syringe, towards the endoscope? Oh, no. Thank you. So because it's stiff, the suction is trying to find its way. Okay. Okay. Can I just hold the scope for 1 second? I want to see one thing. Clean this. Can I have the drill? So normally I prefer to hold the scope on my own even while drilling because it gives me a good coordination for hand-eye coordination. Okay. Irrigation, please. Thank you. Suction. Okay. Yeah. Prakash, now can you hold this? So clean this. Yeah. Okay. Yeah. Now hold. Thank you. So now we have drilled the base of the sphenoid sinus, and now we can drill it towards the septum, going towards the carotid. Again, ideally there should be continuous irrigation that should happen. Because of logistical reasons, we are not able to do that. Can we wash? Thank you. So again, the key is for both the surgeons to work in coordination so that so that there is no sword fighting of instruments in a tight corridor, and they stay in their own sort of predefined area. I think the suction is blocked. Let's clean this. Yeah. Okay. I think suction is not working. Maybe it's turned off. Is there a clot or something maybe? I think suction is not working. Is it switched off? Someone has probably switched it off, maybe. No, it's on? Okay. But I think it's just it's blocked probably. Syringe, saline. Can you have some saline from there?
Hello.
Okay, till the time I'll just show them the anatomy. Suction is not working yet. Can you have the suction sorted? Syringe saline, इसमें डाल इसके अंदर. I think there is clot there. The maximum is it's maximum, right? No, it's no. I think this is the maximum. Yeah, that should be maximum.
Here on the table number 1, Dr. Amol and Dr. Prakash and Dr. Vasundhara is showing the extended approach to the cavernous sinus, and simultaneously we are starting in front of the 11 number AC, the transorbital approach by Dr. Avdesh Jaiswal, head of the department SGPGI, with Dr. Jaskaran Gosal from AIMS Jodhpur. So the transorbital approach, if anybody is interested in seeing the transorbital approach, can come here in front of the 11 number AC.
Sir, can we have the suction ready? It's not working. Suction is not, it's probably blocked. Yeah, now it's working. Okay, excellent. Suction tip.
On this table, in front of the, here we are
Dr.
showing
Sumit
the
is here.
CT angle, endoscopic, and here transorbital. And spine is this side, Dr. Datta is showing. Yes, sir.
All right. So we'll proceed with the drilling. Okay. Thank you.
हाथ में थोड़ा लेट आएगा वो करा
I think शीत निकाल देते हैं, I think. Yeah, मेरे को भी वही लग रहा है.
लोग करते रहेंगे.
Yeah, I agree. It's causing
Dr.
too much of
Kaushal
the-
and Dr. Avdesh is showing the transorbital.
Can you hold the suction? Okay, just hold the suction.
So
Just
we
hold the
have
suction.
Dr.
Then I can
Chakran
work
here,
better.
who is additional professor.
Focus. I think वो fogging के कारण है.
at
Okay, let
Jodhpur
me
AIMS.
try.
And
Oh yeah, I think Dr. Prakash was absolutely right. There was a bit of focus issue. So now we'll start
so we have
drilling
Dr.
the
Jaskaran here, who is additional
face of the
professor
cella.
neurosurgery at AIMS Jodhpur. And
Going
he will
towards
show
the
lateral
tuberculum
aortic
cell.
part, and then I will take over. Okay? So if you have any question in between, please ask.
Okay, syringe saline wash please. From the scope side. Yeah, okay. Thank you. So I think the key in endoscopy is the clarity and visualization to ensure whatever you are doing, you're doing it precisely. Okay. So maybe some more saline, I think. Or I can take out the scope for a second and just clean it. So in real life, when you drill it, ideally there should be an infant feeding tube or a suction cannula right there with an irrigation connected to it. Suction, please, at the clavicle recess. Thank you, Vasundhara. So you can see the clavicle carotids right there. Okay, so this is an anatomical landmark. The carotids on both the sides. So don't violate that area. Irrigation, please. Okay. Let me take this out, clean. Thank you. So again, while drilling, you have to do it in a paintbrush fashion. Just try to eggshell the whole of the face of the cella, and then you can take it out using dissectors. So you can see this is the dura over the cella. Now, this is the anterior intercavernous sinus, which was even visible above the bone prominence also. So there's anterior intercavernous, the posterior intercavernous is right there, and laterally the cavernous sinuses will be more defined once we keep drilling more. Can I biopsy or something? Small biopsy. Thank you. All right. Can I have the drill? Thank you. So, Dr. Prakash, shall I drill the extended and sagittally, and you will do the lateral? Yeah. No. Suction. Yeah. So again, you have to drill it in a way that you don't violate the dura as much as possible. And you should be using a diamond drill. This is a coarse diamond, maybe has a little bit more cutting property than I would really want. So for extended endoscopic procedures, in sagittal plane, this is how you do. And I'm going towards the medial optocarotid recess now. Suction. Yeah. All right. Thank you. Thank you. I think the suction is blocked again. Suction is blocked. Yeah, this is working. So I think you just flush the syringe, flush the suction. Suction cannula. Suction on the clavicle recess. Okay, so can I have biopsy? So you can see a bit of bone chip there and some mucosa, which is still left in the clavicle recess. We need to take that out for more precise drilling and our maneuvers. Okay, so you want the bare bone while you're drilling. And again, million orientation by adjusting the pins towards the scope is the key. Yeah, that's fine. Okay, go down. So now I'm drilling towards the medial optiocarotid recess. So this is important thing to do when you're doing an extended endoscopic surgery. You need to define this area. Otherwise, if you do an extended endoscopic, you'll have a very claustrophobic corridor in the suprasellar area. So unless you define the MOCR on both the sides, that's sort of the gateway to go in the suprasellar area for craniopharyngiomas, suprasellar meningiomas, and other pathologies. A little irrigation. So the endoscope as well as the drill itself produces a lot of heat. So continuous irrigation is the key, otherwise you'll damage the vital structures. So that's very, very important. Okay. Can you withdraw the suction a bit, Vasundhara? Okay, so I'll just drill maybe inferior part of the cell a little bit more. Suction. Yeah, okay, I'll just clean this. So ideally the patient's head should be turned towards our side so that the patient is looking at us, but because of the stiff head and cadaver going into rigor mortis, of course. Okay, so a little bit of relaxed. And those are just some of the prominence in the inferior part of the sphenoid sinus. I'm just drilling that in case you want to do a pathology which is in the clavicle recess like clavicle chordomas or other things. You should be able to appreciate the anatomy well and make your inroads to the target lesion. Okay. So now I'm drilling towards the carotid on the right side. Can I have dissector, please? Dissector. Thank you. Another technique, once you eggshell it, it's thin enough, you can use dissector or a fine upcut to take this bone on top of the carotids out too. But you have to be very careful because you can sometimes bite off the lateral wall of the carotid. So the key is, I'll show you an upcut using a small technique. So you don't, you go there, maybe, yeah, punch it, but then open it. And then use this just to lift it off. So that prevents injury to the carotids. Okay? So you can take a bite, but at the same time, don't pull it. You just sort of lift it, that whole fragment, and see whether there is any brisk bleeding while doing that. Because that will ensure a safer resection, safer removal of the bone on top of the carotids. A little more drill, please. So I'll just drill up for a few more minutes and Dr. Prakash will do the final job of corneal extension. You can show the transpterygoid and other things, right, Prakash? Suction withdraw, thank you. So Dr. Vasundhara is doing an excellent job. Can I have a dissector? This one, yeah. Thank you. Yeah, block. Okay. So flush this. Meanwhile, can I have upcut? Suction ready? Just show me. Thank you. Upcut, please. So this technique sort of ensures they can take out the bone on top of the carotid in very precise and safe manner. So this is the medial part of the cavernous sinus bluish hue that you see, and the cavernous carotid will be, of course, within that. So I think, Dr. Prakash, you can take the honors to do it further. Okay, so can we get the mic to Dr. Prakash? Transfer kar dijiye. So please let us know if there are any doubts at any step.
Maybe just come back a little bit. Come back a bit. I'll just clear off this mucosa on the left side also. And so we'll start from where Amol left off. So you are now getting a very nice view of the gland and the cavernous sinus. So there is one more thing that we can do to expand the exposure more laterally and give us a wider view of structures that are located on the lateral aspect of the sphenoid sinus towards the lateral recess of the sphenoid sinus, towards where the pterygopalatine ganglion is. And that is by doing what we call a classical transpterygoid approach. Now, the transpterygoid approach allows us to expand the dissection laterally. And the transpterygoid approach is based upon identifying and resecting this part of this sphenoid, which is called the pterygoid wedge. Now, we know about the medial pterygoid and the lateral pterygoid wedges itself, but they are anchored to the sphenoid itself by this triangular piece of bone, which is called the pterygoid wedge. Now, there are some other adjuncts that you can use for identifying structures. One of them includes identifying the internal carotid artery by isolating the Vidian nerve. The Vidian nerve forms a very nice landmark for the there's a second landmark which is called the pterygosphenoidal fissure, both of which can be used for identifying this. Now, the first step when you want to do that is to see the posterior wall of the maxillary sinus. Now, just give me the cut. Give this. Cottle. So, as you come inside, the middle turbinate has already been taken, but you can see parts of the. This is the inferior turbinate, which can be elevated to identify the ostium of the nasolacrimal duct. And then after that, you see a wedge. This is called the uncinate process. So when you open the uncinate process, you see three important things. You see the bulla, and then you also see the natural ostium of the maxillary sinus. Now here what I'm doing is I'm raising this mucosa gently, and what will happen is somewhere here you will start to enter into the maxillary sinus itself. So here the maxillary sinus can be seen. You can see the posterior wall of the maxillary sinus inside here. Can you see this? Now, here we have a very important relationship. You have a structure which is called the palatine bone. When you elevate this mucosa on the medial aspect of the maxillary sinus, like this, you see a small elevation of bone here. This elevation of bone is a very important landmark. This is called the crista ethmoidalis. And the crista ethmoidalis forms a very important landmark. It is the landmark for the opening of the sphenopalatine artery. The sphenopalatine foramen opens into the nasal cavity and the sphenopalatine artery comes out of this point. Now, once you have localized this, you can see the posterior wall of the maxillary sinus there. You can slowly open into the this is the sphenopalatine foramen, which I am now opening. इसमें बड़ा अपकट है, बड़ा अपकट हो. डाउन कट हो. आपके पास बड़ा अपकट है क्या? ये अपकट खराब हो गया आपका. नहीं वो इट्स नॉट बाइटिंग. I'm just clearing out the mucosa from here. I don't know if anybody has noticed, but the scope is very hot right now. Okay, so what we can do is we can keep this as a reference. You can just hold it, no problem. Much more comfortable to let you use the scope and I can use the drill. Okay, so from here, what we can do is we can slowly take off this piece of bone. No, it's okay. You can slowly, so what you can see here is the stump of the sphenopalatine arteries. This has already been sacrificed here. But if you trace this further posteriorly, you will enter into the pterygopalatine fossa. The pterygopalatine fossa contains the pterygopalatine ganglion. And the pterygopalatine ganglion contains three important structures or three important nerves that arise and then pass through that. One is the Vidian nerve, the second is the maxillary nerve, which gives some branches and then continues as the infraorbital nerve. And the third is the descending palatine nerve. So what I'm basically doing now is going towards the lateral aspect of the skull base. Here I'm opening up the posterior wall of the maxillary sinus. Superiorly, I can extend this dissection till I see the foramen rotundum. And on the lateral aspect, this gives me access to the cavernous sinus itself. So because on the medial aspect, the ICA has already been cleaned up, it makes life very easy for me. So if you notice, now we have a much wider access to the structures on the lateral aspect of the sphenoid sinus on the right side. And you can see cotyle. So now because the bone has already been thinned out, you can slowly chip it off. So just a little. I will do the Transneuroendocon. सर मैं बस lateral जो वो दिखा रहा हूँ. So now what happens is, when you chip this bone off, you get exposure to the lateralmost part of the cavernous sinus, which lies lateral to the internal carotid artery. And you get a much wider exposure to the So now you can see the entire genu of the ICA here.
And doing
Superiorly
demonstration,
there.
I want to take lots of pictures, okay? Here's my phone there. Hello? Yeah. Go ahead. Yes. As many as you can during the demonstration too, okay?
Cottle. So now, this is the area of the tuberculum. And then here you can trace the optic nerve. So this landmark, this fold of dura here is called the crista ethmoidalis. The importance of the crista ethmoidalis is it becomes the surface reference or surface landmark for the optic chiasm. You have the depression of the optic chiasm on the intercranial end, which is called the sulcus chiasmaticus, upcut.
Can you ask him?
This is called the sulcus chiasmaticus. And by gently chipping the bone away here, you can expose the middle aspect of the optic nerve all the way up to the orbit.
What is he's
even
doing
when
endonasal?
the upcut is not working, you can always use the upcut like a dissector and slowly chip the bone away.
Perfect.
After thinning it out.
Okay.
That is,
We'll have
this is
to
the
wait.
optic nerve on the, and just underneath this you can see the ICA.
Yeah.
And grasper.
What? I will wait. I have to wait.
Come back. So you can see the entire course of the ICA here. You can see the optic nerve superiorly. And this is the opticokerotic recess. This is the lateral opticokerotic recess. The anatomical implication of the lateral opticokerotic recess is that it becomes a landmark for the true optic canal. So the optic canal that passes from the intradural portion has one part that lies beneath the falciform ligament. The part that lies beneath the falciform ligament is not the true optic canal.
Please be careful. We will do the demonstration in a few minutes. Just wait, please. Yeah.
Just ask Dr. Bansal कहाँ पे stop करने का, then they can. Huh? नहीं, अब देख लिया whether I need to open the cavernous sinus. In this table,
yeah.
Should I proceed कि cavernous sinus सर खोल, सूरी सर से because exposure मेरा हो गया. ठीक है. Dr. Ashish Suri. They have done the full exposure. Now, if you want to go to cavernous. There are places, there are spaces where you can go, where nobody can reach. So once we do this, then there is a CP angle going on here. We have dissected, Professor Samar Al-Baba has dissected the CP angle with the endoscope, and they are showing the anatomy, and now he will show some anatomy on the, once they finish with the extended approach. And then on that table, we are going doing transorbital approach by Dr. Jaskaran and
Couple of
Avdesh.
slides, then we'll go there. Yeah. So my friends, please wait, because we have to show everybody. Just, thank you.
क्या?
So we have already done the lateral
अगर कोई
orbitotomy.
नहीं आ रहा है तो I can continue doing the drilling. वही पूछ रहा था. हाँ तो ठीक है. जब तक वो आएंगे तब
So
तक.
this is the zygomatic bone which has been removed.
Come back.
lateral orbitotomy has been done. Now we'll see that we have enough space to work
Come forward.
in the lateral transorbital corridor, right? So this is the temporalis muscle.
So here, I have not opened the sphenopalatine ganglion, but you can drill towards the foramen lacerum and towards the internal carotid artery here by using another landmark, which is called the pterygosphenoidal fissure. So the pterygosphenoidal fissure is a very useful landmark which can be taken. So this is the fissure. This is the fissure that lies between the
Lateral,
the fissure lies here.
So
So this can be used as a good guide to drill towards the foramen lacerum and slowly unlock the foramen lacerum here.
after doing the subperiosteal dissection. Now,
So this is the
which
IC
you're
at the
seeing,
level of
this
the
is the
foramen
greatest ring
lacerum.
of sphenoid. ये retract करना अच्छे से इसको. जो है.
In the spine section, they are ready with the EGGO. They are finished with the EGGO. Now they will be doing the monoportal. Come forward. And then Vasundhara, come forward. UBE later. Interlaminar you will show. We can clear up the clivus here. Yeah, this is the vertical segment of the ICA. And Cottle. Yeah. So when you do this, the entire vertical segment of the ICA can also be exposed, down up till the point where you have the foramen lacerum here. This is not how I would do the foramen lacerum otherwise. Prefer to open the... Are you ready? PCP you can do from here. So no, I'll show. See, the PCP can be drilled two ways, taken out in two ways. One is when you do what you call extradural transposition, where you do it without opening into the cavernous sinus. But sometimes what happens is that your PCP is very high up. It's a very tall PCP. Or PCP lies inside the interdural compartment, lies between the two layers of the cavernous sinus. And when that happens, then you have to open the anterior wall of the cavernous sinus so that you can see enough. So now we have come up to the posterior part, where the so I have done the bony exposure of cavernous sinus. So no, yes, sir. Now, Professor Ashish will show the exploration of the cavernous sinus in this cadaver. Sorry.
Clean कर और ऊपर ले जाओ ऐसे. So that is this is a multi-surgeon creation of a pituitary adenoma. You can have a case report. And this is the cellular floor. The cellular floor has been taken off. And you can see that the dura is there. And these are the 4 blue lines. And we are here. That is the anterior anticavernous sinus.
Thank you.
बायोप्सी फॉर छोटा बायोप्सी नहीं है। कॉल स्टोर्स का कोई है टीम मेंबर्स? सुनील इज देयर? सुनील, so that is the bit of plenum that is coming off. It's already been drilled some. सुनील, आपका हेल्प चाहिए। छोटा बायोप्सी फॉर्सेप है तो बहुत बड़ा है, बहुत बड़ा है। हाँ ये दे दो, बंद हो गया, इसको ब्लॉक हो गया, ये फ्लश कर दो। क्लीन नहीं हो, स्कोप एक बार क्लीन कर देते, तो सेवलॉन नहीं है, स्कोप खराब हो जाएगा ये। सक्शन बंद हो गया, पीछे से बंद हो गया। So, drill is working. Thank you. थोड़ा इसको बीच में कर देते हैं। So that is the plenum. Drilling of the plenum has to be very meticulous. Normally a thin bone.
Sure.
Always
Yeah,
drill in a
It's
parallel
separate,
fashion.
so he can start if you want. We'll just cover this. Yeah, yeah.
Now we just shell it out.
I think I can expose it till then.
Yeah, yeah. I'll just. Yeah, perfect. We should do a group photo outside before everybody leaves. Yeah, yeah.
So that is the dura. That is the tuberculum cellae. Sorry. Okay. थोड़ा सा ये निकाल दिया। ठीक। Suction.
Finished?
You have a scissors, endo scissors. So this is how we cut the dura, 5 o'clock to 7 o'clock. That's for a normal, standard pituitary microadenoma or a macroadenoma. Sometimes a straightforward giant adenoma can also be taken care. Then lift the dura up. Look for the arachnoid vein which comes down. And then and you can bring down the two lateral cuts. So a bit, halka sa withdraw kar sakte ho, space so withdraw kar sakte ho usko. हाँ, that will be better. That is the
How can I
approach for the
help you?
standard pituitary adenoma. I can take off this dura here. Normally it can be, should not be removed. Scissors.
Otherwise, it is very difficult.
Thank you.
That's what I did. I was stealing instruments from here one by one. But you have drill, and you have.
But there is no knife, there is no suction.
We found there's knife and there's
Biopsy?
suction. Where's the knife?
No, there is not there. I already searched everywhere.
Somebody took it.
Yes.
Not working.
I had to do it with
Not
my
working.
hand. and there's
You have
peroxide
done pretty wonderful job, no?
with limited resources.
Koi nahi, I'll use an upcut.
No,
But I
I'm
think
thinking that I will do
you will have better.
Upcut also not working.
vision also.
Sure.
नहीं चल रहा आगे बंद नहीं हो रहा so this till now it's minimally invasive standard I'll mobilize the pituitary gland also flat dissection thank you this is the lateral aspect especially in a Cushing's disease, the one which is going lateral.
If people are interested, simultaneously we can start keyhole kavase on this table on the axioscope. Dr. Sumit is dissecting an opening by the time till the other tables are finished. So you can come and later on and he will demonstrate and you see here. हो गया वर्णन सर का हो गया.
So that is the lateral part. So all NOS1, NOS2 tumors can be approached like this. And you can tilt your endoscope and see a 3A extension like that. Yeah. थोड़ा सा आप अंदर डाल सकते हो वो पतला बायोप्सी नहीं है चल रहा है थोड़ा सा बिट so that is close to the medial wall of the cavernous so this is the one which I believe that is the arachnoid which is usually covers the membrane which covers the fibrous membrane covers the cavernous sinus I don't usually in the first attempt in a Cushing's I don't take off the complete medial wall. That is, I find it much more. But this portion is important. So if you're taking that, that is a 3A extension between the two carotids like that. 3B is different. I'll be drilling some more. Now we'll just take off the pituitary, put it down. हाँ थोड़ा सा सीधा कर बस scissors तो क्लीन कर लें एक बार शबनम आ गया तो उसको भी कर लेते हैं पूरा स्टेम को एक बार वो कर थैंक यू scissors please हाँ ड्रिल साइड पे करेंगे cavernous sinus area now this part of the dura is cut now I'm going for the then we cut the dura parallel to the anterior intercavernous sinus, flat dissector. Take a flat dissector and palpate above and below the anterior intercavernous sinus. That is where the diaphragma sellae gets attached. Scissors. Then we coagulate this. Just imagine this is a bipolar and we can coagulate this and then cut it. That's the anterior intercavernous sinus along with the diaphragma portion I'm cutting. Reflecting it laterally. I'll try to cut this also so that we get more space. Biopsy. Thank you. scissors. थोड़ा सा ऊपर दिखाओ. Then we cut it like a inverted T, the planum dura. ये bone है क्या?
Be careful.
और सौ ड्यूरा काटना पड़ेगा.
Be careful. Be careful.
Upcut. खतरनाक अपकट है. कैडेवर के लिए बहुत अच्छा है. सब कुछ उड़ा सकते हो इससे. ऊपर दिखा दो. This should be drilled, but Sunil has given me a beautiful instrument. Everything can be taken off. So बस ऊपर फोकस कर दो हल्का सा. हल्का सा विड्रॉ करके निकाल देते हैं इसको. पंच मोटा पंच बायोप्सी है. एक मोटा बायोप्सी था ना. Clean.
अंदर 3D ग्लास में.
वापस चला जाता.
You're just doing Kawasaki to me.
अपकट. वो लंबा वाला अपकट था ना. खतरनाक है.
Without any increase of the incision is mostly 4 centimeters or somewhere around this till the zygoma and finding the zygoma there. Mic का जो भाई साहब.
Sumit, this is coming.
Yes, sir. Thank you, Samir. But I will thank only Samir.
Now you can see the two optic nerves. This is the two optic
So
nerves.
normally
that's
this
optic nerve.
does not take so much of time because it's all one incision and you are bang on the
That's the
bone, which is your
pituitary stalk.
area of interest.
और अंदर जा सकते हैं.
This is superficial temporal fascia. This is the muscle.
That is the diaphragma cellae. That is the yes. That's superior hypophyseal artery. That's the carotid.
So
That's the
normally I
pituitary
take this STA back in the posterior flap.
Yes,
यहाँ
it's a
होगा.
straight incision up to the periosteum.
yeah.
Na?
And then we go, and we can even see that. और थोड़ा हल्का सा
Periosteum
withdraw
is
करो.
there? No, periosteum
Then
is
we
not
go,
there.
that is the chiasm. That is the chiasm. थोड़ा सा withdraw करके ऊपर दिखाओ. And that is the arachnoid of the anterior interhemispheric fissure. That is the ACOM, the anterior communicating artery. हाँ सब खोल रहे हैं इसको तुम्हारे लंबे वाले से खोलते हैं इसको वो जो हाँ जो जापानी ने दिया था मुझे
You see the posterior root of zygoma. Oh, thank you.
डॉक्टर ओहाटा ही रिटायर हो गए उन्होंने इतना गिफ्ट दिया मुझे मैंने बोला एक मेरे खराब हो गए बोलता है अब तो कुछ नहीं कर सकता अरे यार जर्मन स्टील जापानी स्टील हमारा भी स्टील अच्छा है लेकिन हम
Knife. हाँ अभी knife.
नहीं हमारा जो अच्छा स्टील है वो एरोनॉटिक और डिफेंस में जाता है अच्छा स्टील तो बाहर मिलता है
So this is a zygoma.
एक्सपोर्ट होता है बहुत then we go over that is the chiasm and we're going above the chiasm that is the lamina terminalis that is the ACOM you can
So
see the,
the
ACOM.
location of this
That is
keyhole,
the
it
A1,
depends on
that is the opposite
whether
side
you want to
A1.
do a Dolenz approach or a Kawase approach. Because if you want to do a Dolenz, then it has to be slightly anteriorly placed. And of course, it depends on
Now you can put your scope inside.
location of the tumor, in which
Yes,
particular area you want your epicenter of the tumor is there, then you will place your
इसको
keyhole
निकालता हूँ ना, चलो, एक
on that
section
area.
निकाल
Of
लेता हूँ, तो
course,
वहाँ पर जगह बढ़ जाएगी.
navigation plays a key role.
Here.
I'm not denying this. Without navigation, it is difficult
Yeah.
because keyhole, your spaces are limited. So you have to be very, very meticulous about the placement of his keyhole here.
थोड़ा सा और निकाल देते हैं बोन आवाज से क्या करना है काम से
Do we have a mop here? No? Okay, thank you.
वो कहाँ गया स्पैचुला लंबा इससे और लंबा भी है सेक्टर लंबा और है ये क्या है ये तो खतरनाक नाइफ है
So normally you don't have to work so hard in retracting the tissue, but that's okay. This is the cadaver, so even if
No,
it is
we open
this
the
is a
lamina
fresh cadaver, it
terminalis.
seems. But yes, you have to
that is the lamina terminalis open
sometimes work hard.
Dr. Amol will put his scope inside
Nice.
and show you yeah that is the third ventricle you
Slightly,
can see
I
the
may
foramen
have to
Monroe
extend this
on
because
both sides the choroid
obviously this
plexus
is not the
that's the
ideal
interthalamic
situation there.
connexus ना ना इसको सब कर देंगे थोड़ा सा अच्छा हो जाएगा हाँ चलो
Okay.
आप डालो that is the
So
that is
these
the
are the two
interthalamic
landmarks
connexus.
that you have to expose. This is the posterior root of zygoma. This is the anterior end of the zygomatic arch here, actually slightly more. So this is the root of the zygoma from here till here. This is the anterior end of the root of
Yeah,
zygoma.
that is
This
the
posterior
interthalamic
end.
connexus, and if you
Your
follow
entire
that, you'll
focus
have
is
the
on this
ventricle,
area from
the
here
aqueduct
till
coming
here.
back. That is the
Because
aqueduct.
it is
6
here the
o'clock is the
Dolenz,
aqueduct.
the
That's the posterior
Kawase
third
triangle will
ventricle.
be there. And this is your area of interest. I would be more happy if I would have exposed a bit more, which in life situation I would have done so, even with a smaller incision. But yes, I mean, these are cadaver, because I always see the whole of the posterior root of zygoma, and then I'm confident about. So that is what I'm trying right now. No. Okay.
Section नहीं मेरे पास ठहरो है
So
इस साइड
can
पे
I have a drill?
अच्छा फिर तो इसको क्लीन कर लो फिर
No, normally I don't do it, but I don't go beyond this area, below this area. No, I don't remove zygoma. There's no need absolutely to remove any zygoma in the keyhole. So no, but this is, I mean, obvious. This is a tough tissue, so that is why I'm going so much of down. Normally I remain till here only. From here till
that
here
is the
at the
carotid.
most.
I'm lateral to the carotid here. And then, acha, okay. Dr. Amol and Dr. Prakash have nicely done this exposure.
Yes, this is mandatory because it is this is your area of interest. This is your area of interest where you have to work in a Kawase triangle.
Use it like an elevator.
From the base? Yes, of course, yeah. Now it's okay. No, this is maximum zoom. Maximum out. हो रहा तो maximum कर दो. Drill, please. We have a drill here. B1, I have a B1. So when you are making this, you have to be very careful. No tear of the dura happens. Otherwise, I mean, it will become a mess.
This should be drilled ideally.
Temporal lobe comes out and all, everything, problems happen. So it to be very gentle and dura nahi phatni chahiye abhi. Early rupture of the dura should not be there.
Suction is
आ जाएगा अभी नापिंग में आ गई ना सर हल्का सा भी ड्रॉ
हो गया शायद नहीं हाँ रुका नहीं यार ये अच्छा हुआ फट जाती नहीं तो ड्यूरा हमारी हाउ टू गेट रेड ऑफ दिस भाई नहीं है ना इट्स डिफिकल्ट
थोड़ा सा अंदर जाओ
हाँ जी No, there is no irrigation somewhere. It will be. Yeah, I can mop. Yeah, if you can. Yeah, please. Thank you.
तो तोड़ देता हूँ बोन को
It's all stuck. Can we have this more, huh? Please.
एकदम मिलता जा रहा
उसमें B1 लगा देना You have a upcut? Upcut है यहाँ पे? नहीं?
चलो
कोई बात नहीं.
कैरोटिड देखिए घूम गया कैरोटिड आ गया इसको कर देते हैं थोड़ा सा दिखाओ लैटरली Yeah. That's the cavernous sinus. Now you can see the nerves, lateral wall.
B1 नहीं है, B1 is not there. Striker से कौन है?
That's the anterior.
Keyhole. This is a Kawase approach with the keyhole. Can I take this? B1 लगा देना.
And now you see the perforators are coming from the lateral wall.
Iska-
That is why you shouldn't use a curate here. Upcut.
नहीं है.
3 आएगा, 4 आएगा.
If Dura tears, then I am helpless.
6 आएगा. 6 तो अंदर आ जाएगा. lateral
करना पड़ेगा.
So lateral दिखा दो.
No problem. I will come from here.
एक बार क्लीन कर देंगे. दो clean. Now you can see that is the carotid. Yeah, that is the carotid. 30 भी लगा सकते हैं. हाँ वो लगा लेंगे. पंच बायोप्सी दे दो. 30 दे दो.
Periosteum. Okay, so far so good. Boss, can you raise this, no? My mask. Thank you. ये थोड़ा और मिलेगा क्या?
Now you can see the cavernous sinus. Suction, upcut.
हाँ, gauge piece. I want to clear this mess around here. Yeah, is it working? नहीं, ये काम नहीं कर रहा.
ले जाओ ले जाओ. आ जाओ. Lateral देखना थोड़ा.
बड़ा मुश्किल है इसके बिना. Suction कैसे चलेगा नहीं?
थोड़ा सा विड्रॉ करो हल्का सा. थोड़ा विड्रॉ करो. हाँ बस.
Let's see how can we do, because many things are not there. Give me number 4, please.
Flat dissector.
इसमें रखा था ना अभी मैं. हाँ ये.
Flat dissector.
ये फोकस कैसे होगा? ये क्या हो रहा है यार? बताना कोई एस्कुलेप.
Now you can see the third. ये आ गया third.
ये फोकस
That
कैसे
is
होगा
the
भाई?
third nerve.
अरे नहीं अभी नहीं हुआ. यहाँ पर नहीं
That's the
हुआ.
cavernous sinus. And that is the 3B extension of the tumor. So withdraw कर. हाँ. That is the 3B extension. ये भी काट के दिखा देते हैं. Clean करना.
सही नहीं दिख रहा है इसमें.
गंदा हो गया. जगह बहुत कम है. हाँ यहाँ वो तो है.
दिख नहीं रहा बॉस आपके माइक्रोस्कोप में.
कुछ भी नहीं था. बस हाथ.
हाँ अभी ठीक है. So you know this.
That is the 3B.
This ledge of bone, no, this is coming in your way right now. So you need to remove this so as to increase your angle of vision.
That is the 3B extension.
ये drill मिलेगी क्या? AM8?
ठीक है हो गया. और कुछ दिखाना है बस बहुत है.
AM8 drill मिलेगी क्या? एक मिनट. Let me. I have to reposition it again. हाँ एक मिनट. इसको निकाल ही देते हैं यार. See, I do not do this in real life, but of course, here I have to remove this to increase my vision. Otherwise, I will not be able to.
ये माइक उतार लो, ये माइक उतार लो, इसको यहाँ लगा दो, ये माइक ले लो.
Okay, thank you. You have a periosteum. Okay. तो एक अपने ने वो देखा था, ब्रेन स्पेचुला रखा था वहाँ पे. है क्या? हाँ, है क्या? दे दीजिए मेरे को.
Okay. So this is your.
इसका फुट स्विच देंगे क्या प्लीज?
Optic strut.
इधर.
So this is your LOCR is basically
Thank
optic
you.
strut. And once you define the optic strut, you can actually
So
look at all
हाँ
the
ये
things.
ना.
So this is the
rotate
third
कर
nerve will
लेते
be
हैं
the
अपन
superolateral
ऐसे.
tube. And this is your optic nerve going. And if you enter from the medial aspect of the cavernous sinus, you can. Is there a sickle knife? I think there was a sickle knife here. I think that will be much better. There was a sickle knife. I saw that.
You can remove this flush with the base. This is cheating. This is cheating in a keyhole. You are beveling this keyhole so as to increase the vision or angle of vision.
Okay.
अपने पास वो है क्या?
So sickle knife is a good instrument to open up the dura on top of the, even to dissect the mucosa as well as to open up the dura. But again, ideally, we should be doing it the other way around so that the carotid doesn't get injured. So we go in like this and then dissect it towards the pituitary rather than towards the carotid. If you do it like this, it can just puncture the carotid, right? So that's something in real life you should know. But I mean, diamond knife is another good option. This is a piece of bone. So diamond knife is a good option if you use it. It can just open up the dura in a very precise manner. And it is translucent, so you can see what exactly you are cutting. So that. Yes.
Number
So I'll
4
show that.
dissector.
So ideally, I mean, this bit of bone was stuck. This is part of the last part of the medial optocarotid recess. So this is you can see that once we remove that bone, you can open up the area a little bit more. Dissector, please. No, dissector. Yeah, thank you. This is also good. We can try this also. This has little
Drill.
longer and bigger. Okay. So again, there's a concept of medial cavernous wall resection, which is being propagated nowadays to increase the remission rates in functional pituitary adenomas, Cushing's, acros. So you open up this medial cavernous wall, and you want to divide it. There's again is a carotid clenoid ligament which goes there, and there is usually a small artery. You can just divide it sharply. Once you have the
Without section,
scissors,
it will be difficult here.
this is scissors, yeah. So once the anatomy is clear, you can actually divide it quite safely,
काम कर रहा है ये.
preserving the carotid, of course, and even the pituitary gland. So even like Sunil was asking about the pituitary transposition. So pituitary transposition, one option is intradural transposition. You open the dura and do it this way. Take out the gland like Dr. Surish suggested, and we open and just mobilize the gland from one side of the cavernous sinus. This is interdural, between the two layers of dura. This is another transposition maneuver. Yeah, exactly. So this is between the endothelial and the meningeal layer, and you can open up the attachment of the pituitary towards the cavernous
So
sinus
I
on one side,
need to
and you can
drill
mobilize
a
the
bit
whole
more
complex as one.
when I will be flush with
So
the
that
base.
gives an advantage of if you have to go suprasellar, if you have to remove the posterior clinoid later on for chondroma or chordosarcoma. That is an advantage that this technique can actually offer you. Yes. So one side inferior hypophyseal artery goes, and carotid clinoid ligament has to be
ideal
divided, and then
situations are not there.
once
I'm
you do this,
sorry.
the gland will give you more
but,
space to work in this area. Okay, and you remove all the soft tissue and the ligamentous structures between that. So I think it was Dr. Prakash who showed in one of the papers that medial cavernous resection increases the, yeah. So usually if you divide them away from the carotid by coagulating them,
डालिएगा थोड़ा सा.
then it's okay. But if you try to pull it,
कर रहा है
yes.
काम.
One side is okay.
No, it is
Yeah.
not working. Yeah.
Quite away. Yes, yes. So that's very important. Otherwise, if you create a buttonhole in the carotid, it's just the you'll be eating your lunch early. You know, so, so that's the only thing. Yeah, that's, first up, DI will happen if you get the pituitary stalk damage. Otherwise, just one side transposition, there can be pituitary insufficiency which can happen. But already many of these patients have, from the tumor
करिएगा.
itself causes insufficiency.
This
So
is
once
not
you
working.
have, so you can see now I've transposed the gland towards one
Suction की
side
बड़ा मुश्किल है. हाँ.
and just yeah, this one it's turning. So this is your PCP. This is a posterior clinoid process. You see that? So this is a posterior clinoid process. Yeah, the dorsum cell. This is the highest point of the dorsum cell. Okay, so this is a posterior clinoid process. You can see that? Okay. Yes, because of the chordrosarcomas and chordomas, it sort of. Okay, can you clean this? Since we don't get ENT expertise like ma'am does and for PGI, so we hold our endoscopes ourselves. So, so yeah. Yeah. Oh, that's very good. Yeah. And then, yeah. Can I have for the cholesterol granulomas? This is the point. Yeah,
अच्छा,
that's
एक इसका इंतजाम करना पड़ेगा ना. इसके सक्शन का कुछ इंतजाम करना पड़ेगा.
with Janki Ram.
Otherwise
Yeah.
कैसे होगा?
Scissors. Maybe upcut is fine, I think.
यार कहीं और पे अच्छा सक्शन नहीं है कोई किसी टेबल पे मारिएगा जोर से.
So again, you have to be meticulous in your work. And if you're precise enough, even Dr. Janki Ram was in AIMS about 10 years back. And yeah, he's a wonderful guy. Very good clarity in anatomy and yes. Yeah. Okay. So passed on the baton to the next generation. Dissect. Yeah. Thank you. So this is the paraclavial carotid. Biopsy. This one.
No, sir.
Yeah, I mean,
No, never, sir. It is not required actually. So this is the base. So there are several undulations on the temporal floor, though you can drill it with a micro drill, 2 mm drill.
I think he moved few years back. Assam moved to another place, right?
So this undulation is obstructing your vision. You can.
I think Canada also he was there for some
I
time.
can do it.
Yeah.
नहीं ये
Dissect.
focus कर दीजिए.
Thank you.
Drill दे दीजिए. चालू है. Very nice. अभी सक्शन चल जाए बस. सक्शन करेंगे क्या? Is the
Exoscope. Okay.
middle meningeal artery, you can see that already coming into view.
Yeah.
Yeah,
So you can see the pituitary. Yeah. So pituitary is like because it was already dissected from one side, and now we have dissected from the other side. So now it's like a free floating gland. So you can actually do one side wherever it's required, and then take out the rest. So I can just use sponge to remove the pituitary gland because it's in our way. This is scissors or possible. This is true cut. Okay. I'm gonna biopsy. Do you have biopsy or something? We'll just remove the gland, and we'll define the posterior clinoid and maybe drill it, and you'll be able to appreciate the able to appreciate the third nerve anatomy the basilar and the SCA PCA complex
Some
can be
more
very well
bone work
visualized.
needs to be
if you
done
drill that.
posteriorly.
Biopsy again, biopsy. Thank you.
Here, sometimes the air cells come, so you need to take care of those air cells. Once you close, you have to wax them, otherwise
I think this was
otorrhea
not-
can
this
happen in
doesn't-
the post-op.
Either nahi pakad raha. This is
Wow, see,
This
this
is
air
the
cell
front
has come,
angle.
no? Yeah. Suction, please.
I think uska alignment problem hai ya
Ah.
kuch hai. Yeah. Okay, suction. So now you can see this is the dorsum sellae and the posterior clinoid on one side, the posterior clinoid on the other
It's
side
so
is here.
tight, it's causing ischemia of my hand.
And once we drill this, drill please. So I can just drill that posterior clinoid. Can you take this out? Yeah. Oh, thank you.
Suction is working
Sorry,
or not?
Clean. Underscore.
Ah.
Yeah. Thank you.
So partial success is when you maintain that the dura does not get torn. Otherwise, brain gets all the problems start happening. So this is the stripping of the dura off the base. He does not have any other size, actually. This is 6.5 and my size is 8.5. Section.
Saline. Okay.
So your entire this thing should be from posterior
Clean,
root of the, posterior end of the posterior root
Thank you.
to the anterior end of the posterior root, from here till here. Oh, thank you so much. Yeah.
I think suction block. Maybe at that junction.
Yeah, I should have brought mine actually. I'm so sorry for that. I thought
Yeah,
that
right there at the junction. That's it,
Bansal
yeah.
sir.
No, I think the problem is at the junction. So once she takes out the bone dust from there, because that's the bottleneck. It's a connect. वहीं अटक रहा है. Yeah, thank you. Thanks a lot.
Pretty much comfortable. Thank you so much. Dr. Vernon, thank you so much.
Drill, please. Thanks.
So you're slowly reaching till the middle meningeal. Suction. नीचे गिरा दिया था.
Clean. Thank you.
This is the middle meningeal artery. Okay. Can I have the number 4 dissector, please? Here.
No, I'm okay. The suction is again blocked. I think there at that point. It's working, or maybe then it's just the tip.
इसको थोड़ा ऐसे इसकी पोजीशन
चल, कर
कैसे
ले फिर
चेंज
suction.
करेंगे?
All right.
ये है.
Suction.
नहीं, यही है पोजीशन.
Drill.
ये थोड़ी फाइन वाली है. ये फोर्सेप्स फाइन है हमारे पास. डेप्थ में फोकस कर दो. हाँ. suture है हमारे पास क्या? So what I normally do is I
So
don't
this is the
retract
clavus
it
dura,
with
which is now
spatula.
sort of starting to come out.
I apply one
For
suture
claval
here.
chordomas and chondrosarcomas, this
ये
is where
depth
you
में
have to drill.
focus कर देना.
Yeah, this is proper clavis. This is upper 2/3 of the clavis. Yeah, वो नीचे
नहीं,
आएगा.
हाँ, yes. ये इसकी पतली
Longest
है
for
हमारे
life.
पास क्या? ये पतली है. फट जाएगा नहीं तो ड्यूरा.
Yeah.
नहीं यार इससे नहीं होगा
Yeah,
बॉस.
syringe, saline or something. Can you clean the
You
scope?
need micro instruments for this.
Clean
No?
the scope.
मैं लाया नहीं, मेरी गलती. अच्छा एक काम करते हैं. सूचर भी नहीं है ना?
Suction piece. Oh, I have it. Yeah.
एक काम करो बेटा, ये can you hold this so that I can cut this at the first step? है ना? ऐसे कर लो, हाँ?
There's a
So
cotton
can you give me
Clean
micro
this. There
scissor
is a
please?
cotton thread.
So
Thread
this
on
is the
5
first
o'clock, 7
step
o'clock.
which I say when you reach you to cut the spinosum. Take care that this middle meningeal, you don't cut it very close to the foramen
Okay.
spinosum
Can I
because
have,
sometimes it
dissector?
retracts and then it
Dissector
becomes
now?
difficult to.
Thanks. So again, you can see the posterior clinoid, most of it is gone. It is, decannulated, it's not completely removed. So I'm using the dissector
चलो.
sort of mobilize it. I think it will need a little bit more drilling.
You have to obviously cut it.
Upcut. So maybe smaller upcut I can use to sort of punch it.
So normally you have to take a micro rotten dissector for
So
this.
laterally, please.
This number 4 is not allowed. These are all micro instruments that you have to use, of course.
Upcut.
अभी मैं इसको
Yeah,
ऐसे
45.
ही.
We
Knife है
can have
क्या आपके
45.
पास?
45 कर सकते हैं. Maybe we can. I think better है. That's true. Manage most of it, yeah. But this is like an extreme angle for the.
Oh, wonderful. Oh, that's a luxury. Thank you so much.
Clean this. ज़्यादातर 30 से हो जाता है.
Yes, we have cut it. Normally
draft
we
के लिए.
don't cut it like that.
70 चाहिए. You're right.
We coagulated both the ends. Take time to cut it because
Upcut,
this
down cut,
can
down cut.
ruin
You have a down cut?
your surgery.
Yeah, that's good. Thank you.
Take proper time to deal with this and then advance accordingly, okay? Number 4.
Clean. सुनील का पहला सवाल था CSF लीक कैसे प्रिवेंट करते हैं. ऊपर जब वन आशीष सर याद है.
Suture भी नहीं है ना? Can you decrease angle? I want to look straight down. ये angle से दिखा रहा है ना? आप इसको ऐसे कर सकते हैं. हाँ ये हो गया. अभी फोकस कर दो. हाँ?
Charlie, sir, craniotomy done. Endonasal craniotomy done. Suction.
फोकस कर देना. हाँ.
Opening the
Dissected.
sickle ने.
Dissected.
ये basilar plexus. हाँ.
और थोड़ा शार्प होना हो सकता है
This is
फोकस क्या?
basilar artery.
अभी ये
We'll use
ठीक
a sickle
नहीं है.
knife, like
नहीं.
sir suggested. Ashish sir suggested. Yeah, I know, sir. Yeah.
ओ आ गया. ओ भाई. हाथ से लगा देंगे. नीडल लोडर नहीं होगा तो. आर्टरी.
Okay. Yeah. Upcut. Upcut. Give me upcut.
जुगाड़ हिंदुस्तानी. अब कैसे पकड़ें?
So basilar.
देखो, dura foot
people
ना
have, like Ashish sir was telling that people have done
Give it to me, give it.
This is not a good bite. Yeah, the big, thank you. So we're using this spine instruments for the brain. And
Yes.
Carl Stores का already draft 3.
Can you give me suction? अगर चलेगा तो ये because
Yeah,
suction comes in
aesthesia
really
neuroblastoma
handy
के लिए
at this stage.
for the draft. Yeah.
Focus कर देना भाई.
So you can see this elderly gentleman has a calcified plaque in the basilar.
So
can
you
it's
see
a
this?
Yellowish. Yeah, yeah, yeah.
This is नहीं इस एंगल से देखा इस एंगल से.
So yeah, so Haddad plaque has to be really like
Come on.
yeah, but I think the 30-degree scope has more clarity. Its quality is better because it's useless. इसके हमारे optic cables are better.
No, 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 no.
हाँ, हाँ.
Give it to me.
चलने दो. Just show me. Just let me hold it myself now.
ऐसे कर लो बेटा हाँ. और
मैं एम्स में डॉक्टर सूरी से
you see this is
वही हो गया कुछ नहीं.
इसमें और पतला नहीं है क्या अपने पास नहीं है.
हाँ हाँ मे में नहीं अभी आ रहा है मार्च में.
That is what I am tracing.
April
Sir.
में
I think this should be.
dissector something. Yeah, thanks. So you see the basilar all the way. Can I have upcut? Punch. Yeah, this one is fine.
Wait, I'm doing it here. You don't do anything.
वही प्रॉब्लम है. Yes.
छोड़ना है इसको बेटा.
हर एक स्टेशन को 1 घंटा दो.
Yeah. So you have to develop this plane. Now this is the step 2. You are working. You are separating, stripping dura.
Okay.
Normally I do it with a flat dissector,
Dissector.
which is
Acha.
not here unfortunately.
यादव सर
This
के
is
साथ.
peeling out quite well. So this is the interdural plane that you should recognize, no? This is a very important plane. You should not lose this plane because especially एक मिनट मैं just a minute मैं पकड़ाता हूँ आपको ना मैं पकड़ाता हूँ इसको थोड़ा depth में कर देते हैं. Because it bleeds like sometimes it bleeds like hell actually, so you do not have to worry about the bleeding and all
This is your
aspects.
third nerve. This is your superior
And
cerebellar
surgery
artery.
flow comes in very handy
SCA
at
and
this
PCA.
moment.
So between the PCA
ऐसे
and the
पकड़ लेंगे क्या?
SCA, you get to see the oculomotor nerve.
Dissector मेरे वो Caesar
This
होगी
is
ना?
your PCA,
नहीं
posterior
मैं जो
cerebral
Caesar
artery.
ले रहा था
This is your superior cerebellar artery.
अभी इसका फिर से
Yeah, this
ठीक
one.
नहीं है.
And this is ICA.
ऐसे
This is
जाना.
ICA. ICA. Anterior.
हाँ, अभी ठीक
This is
है
third
ना?
nerve.
हाँ.
Yeah. So you
Lana?
can appreciate the anatomy there.
So it has to be a sharp dissection here,
Six
either with
now
a
will
flat
be-
dissector.
Right there.
So remember, if you are interdural, dura will not
Point.
tear.
So CSF leak
So
is
I
a
can
very
see the fifth nerve
genuine issue.
fibers already.
That can happen.
And this is the
Sorry?
facial hiatus.
Trigeminal neuralgia you can do, but the problem is the reconstruction.
I am
It's too big a reconstruction
shortly
for a
about
small
to reach the
benign
cavase.
pathology. For malignant disease,
Rhomboid.
if it's involving the base like
See,
chordomas,
you need,
it's fine.
we
But
need
for
one more
trigeminal
this
neuralgia, I
thing. Can you
think
give it
MVD
to
is
me,
the
the
best.
suture, no?
Transcranial craniotomy is the
अपने पास
best.
आर्टरी थी ना कोई कह रहा था
upcut.
आर्टरी है.
Upcut or downcut. Now, do you have downcut?
So you see, you need not have to have more than this space for a cavase. So I mean, this is more than enough space to do anything which you do with a cavase rhomboid. So if you want to do an anterior petrosectomy, you can very well do with this. No, there is no point in doing massive skull-base exposures and all. भैया थोड़ा सा फोकस कर देंगे क्या? बहुत बड़ी नीडल है. Normally मैं ऐसे नहीं करना चाहिए. It is a sin.
This is basilar artery, and this is your SC and
अभी
PC and
फट
third
जाएगा.
nerve,
नहीं 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 नहीं.
right there.
Oh God. अभी देखो अगर ये अपने आप होल्ड कर ले साला तो अपना वो कहाँ है? हाँ. So normally what I do, I
Aircard,
take a
aircard,
stress
no?
suture
अभी मैं
very
गया
very
था,
deep
NSI में.
here,
I was at
somewhere
the
here.
workshop. Yeah.
So use that
Aircard,
vontage.
it's a
Focus कर देना
French.
भाई, पकड़ लेना.
Clean, clean. Clean. Yeah. Strasbourg, yeah.
अरे क्यों हिल रहा है भैया?
So again, telling you the anatomy. So there's a basilar artery, your PCA, SCA, third nerve, right there. And your anterior inferior cerebellar is here. On the other side also it was appreciated. Over here, anterior
Focus
inferior
कर दो
cerebellar
बेटा.
artery. Sometimes you can have actually two superior cerebellar also. Probably maybe there are two superior cerebellars rather than
हो रहा है
ICA. ICA is usually a little lower. Over here, suction.
नहीं भैया
Can you clean
focus
this,
कर दो यार.
So the key is to understand the anatomy.
देखो डेप्थ में फोकस कर दो बच्चे.
That's a
नहीं,
brainstem
ऐसे नहीं,
perforators.
मैं
This is your
बताता
ICA.
हूँ. अच्छा मुझे दे
This is
दो.
your ICA.
आप
This is
सब
actually your
करेंगे
ICA.
क्या?
Okay. You can
मुझे
see
दे
the
दो इसको,
perforators,
मैं
and the
try
7th,
करता
8th
हूँ.
complex will be
It has to be
behind
a
this
self-retaining
arachnoid.
here.
Once you open the arachnoid at 3 o'clock, you'll see the
Focus कर
7th,
दो
8th
बेटा.
complex. And again the ICA on the other side. ये ICA, ये actual ICA. वो वाली
Focus-
that was superior
अच्छा, एक
cerebellar का ही
मिनट,
दो
इसको और
branches था. So sometimes superior
perpendicular
cerebellar
करना
has variant of two branches. So this side has one. So that's
क्यों
the-
हिलता है यार ये ऐसे? बैलेंस नहीं
I
है
think,
क्या?
I mean, if we go further down, like for that, you have to open up this guana
Focus.
and divide the dissector.
Focus. अरे भाई
वो
क्या
नीचे और
करते हो यार?
So, for looking at the hypoglossal, you'll have to open up the
हाँ ये.
sixth wala, I think, just यहीं पे दिखना चाहिए, sixth nerve, but I'm still not able to be sure about it. Let me see. I think should be behind the arachnoid. I'll just open the arachnoid a little more. Yes. Upcut. Thank you. Absolutely. Yes.
यार फोकस तो कर दे. ऐसे कैसे करेंगे भाई?
Onodicel, agar nizai, everything.
ये ठीक नहीं है क्या? क्या प्रॉब्लम क्या है इसमें? हिलता रहता है ये, पता नहीं क्या. नहीं फोकस नहीं, सेंटर करना हूँ मैं एक्चुअली. फोकस करो अब.
Sixth nerve should be right here. If you open up the arachnoid a little more.
ऐसे पकड़ोगे क्या?
Sixth nerve should be here. Maybe some arachnoid is preventing it.
ये पोजीशन क्यों नहीं हो रहा?
Anyways, I mean, if you keep drilling this
अरे
all the
यार,
way
इसको
and reach
फ्री
to
छोड़ दो ना
Alquana,
यार.
then you'll be able to see the hypoglossal canal, the jugular tubercle, and everything. For that, we'll have to go all the way
नहीं
down.
मुझे ऐसे मुझे
But I
खुद
would
ही करना
rather
पड़ेगा ना
want is you guys to do some hands-on practice. Okay. So,
ये
so
वाला?
that you get the feel of how to do it, drill some area, dissect some area, so that you are more confident tomorrow that you can do it in
अच्छा।
your real practice. Okay.
मुझे
So
इस
please
एंगल से देखना है मेरे को अगर
explore,
इसको
and then I'm here to help you.
यहाँ तो उधर हो रहा है
तुम कहाँ से हो? देहरादून से, अच्छा अच्छा। हाँ अरे मेरा था
फोकस कर
क्या
दो
है? अच्छा मास्क पहन रखा था ना, अभी तो कल डिनर में ही था। चल बढ़िया। सो बेसिकली आइडिया है कि
हाँ।
जितना हैंड्स ऑन प्रैक्टिस करोगे, हाँ क्या है? निकाल।
है क्या देखो यही लगा के देखो क्या
CP angle. Quick. Top. Yeah. Himakshi. Okay. Take few. Also here, from here.
मैं पकड़े हूँ अदरवाइज इट विल बी वेरी डिफिकल्ट हाँ ये ले लो
Can you please change, please? Hello? Yeah.
फोकस करना और सीजर देना सीजर अरे यार क्या कर रहे हो तो फोकस कर दो यार ऐसा कैसे करेंगे यार
That's right. Thank you. Bansal. Bansal. Oh my God. Hello? Yes. No, I don't. Yes, find a place with a good rate around 90. Just convert. Fine, go ahead and convert $100. Sorry? Yeah, he's now with them, with the boys somewhere. He's calling all the time. Thank you. Bansa, are we ready? Well,
Hello, friends. In the front, Dr. Samar is going to show the CP angle anatomy. On the right side of me, Dr. Sumit is showing keyhole Kawase with the exoscope, robotic exoscope. And here we have finished the transpenoidal endonasal extended approach. Then we have finished the transorbital. And in the last table, we are starting the UBE. Those who are interested in spine and UBE, they can go back on the last table. And somebody is showing here the CP angle approach, which he has dissected half an hour ago about the CP angle keyhole endoscopic approach.
okay, so
Somewhere here.
thank you. So thank you, Professor Bansal. So we'll talk about CP angle endoscopy. We'll show a few slides only very quickly. So it's very important for the participants to know the differences between endoscopy, endoscope-assisted, and endoscope-controlled approaches. What we will talk about today is mostly with a CP angle, we do endoscope-controlled surgery, which means the endoscope is used for visualization only. When we tomorrow, during the lectures, we'll talk about pineal tumors. We'll talk about the differences between endoscopic, endoscope-controlled, and endoscope-assisted approaches. So whenever we deal with a CP angle, obviously we need to identify the cranial nerves and the vessels associated with them. We can see in the CP angle, whenever we do the CP angle, the approach from all the way when we see the tentorium, and in the specimen, we can show you beautifully the tentorium, the fourth nerve underneath the tentorium. Then we start seeing the fifth nerve. Above the fifth nerve, we call superior triangle. Then the central superior triangle between the fifth and seventh complex. We need to remember the blood vessels. At the fifth nerve, always we have the superior cerebellar artery running with it. 7 and 8, we have the ICA. And whenever we go 9, 10, 11, we start looking into the pica. And if we want to see the vertebral, we need to go to the 12th nerve and look very inferiorly. So here, those are the triangles we're going to go during, in the specimen, we're going to go between the cranial nerves. And in the specimen, we're able to dissect from the 4th all the way down to the 12 nerves today. We'll show some cases, couple of pediatric cases. This is a child with a large prepontine mass. You can see all the corticospinal tracts and DTI tractography pushed backward. Anytime we want to approach this area, the cerebellopontine angle, regardless right or left for this midline mass, we should know the anatomy. And the anatomy we should know from, again, from the 4th all the way down to the 12 nerves. Most importantly, not only the anatomy, but the arterial and venous systems. Most of complications in posterior fossa surgery are venous more than arterial. So the anatomy of the transverse and sigmoid sinuses, as well as the superior petrosal vein, as well as whenever you do the supracerebellar approach, all this venous anatomy is very essential. We'll talk about it tomorrow in the lectures. So very important to identify the anatomy. Whenever we do CP angle surgery, we need to know the asterion. We discussed with some of the young doctors a couple of opportunities, a couple of ways we can find the asterion. Using anatomical landmarks. If you draw a line between the zygomatic arch and the inion, external occipital protuberance, if you draw a line between the zygomatic arch and the inion, and you divide it into 3/3, after the 1/3, it will be the asterion. Another way to do it, actually, if you feel the mastoid notch, and you with one finger behind and one finger above, this also will be the asterion. We'll show it in the specimen. We start typically by doing a very small, here's this. We talked here about, here's the mastoid notch. If you put one finger here and one finger here, you should be able to get to the asterion. And you start by doing a burr hole. When you do one burr hole, you take your time to work with extradural dissection to find skeletonize the transverse and sigmoid sinuses. You want to always have transverse and sigmoid sinuses, so you start the burr hole in this area. In this case, we did a craniotomy extended from the burr hole. Now you can see now we're doing the dissection lateral to the cerebellum. We entered this mass. It was a neuroenteric cyst. And now we start thinking about getting into the windows between all those cranial nerves. But very importantly, when we deal in the CP angle, we should always think about the perforators of the basilar artery. Like in this case, you can see here, here's the basilar artery. Here's one of the perforators, all wrapping around the mass. So a sharp microdissection is your friend. Here you can see we're dissecting the cyst of the mass of the basilar artery perforators. Now we go through all those triangles. Now we finished all the work. Now we can put the endoscope. You can see here 5, 7, 8, ICA. Now, this is the basilar artery, and this is one of the perforators. And now we're looking at the actually internal auditory meatus on the other side. So you can use the endoscope or microscope. Microscope will give you a good view of the CP angle, but the endoscope will allow you to go to the other side. And this is on post-operative day 1. And this is after 6 months. You saw how the brainstem retracted beautifully. This is another child a few months ago with extensive ependymoma in the CP angle that goes also into the internal auditory meatus. Same thing we do with, in this case, surgically. You can see here there's no anatomy. You're looking, the tumor is wrapping around everything. So we take our time, microsurgical dissection, then we bring the endoscope. And now when we bring the endoscope, this is the view we're going to see in the specimen. This is after we took out the ependymoma. 7 and 8, you can see internal auditory meatus. All the tumor in the meatus is removed. 4th nerve, 5th nerve, superior petrosal vein. Sorry, 5th, 7, and 8. 4, 6, 5, 7, 8. Now you can see 9, 10, and you'll see the 11 coming down vertically. And we're going to look at the specimen. We have to remember, the vagus nerve is like your hand, fingers, okay? And the 9th nerve is always very thin, alone, above. And the 11th nerve is always vertical, coming down. So you start from the top. We will look at the specimen. Under the tentorium is the 4th nerve. Then the 5th nerve goes, it's thicker, goes into the base of the skull. Then the 6th nerve is behind. We come down, we find 7 and 8 on top of each other. 7 of 8 always attached to ICA. And 8th is always on top of 7 as in the meatus. Underneath we see 9 alone. Then the hands of the 10th nerve vagus. Then vertically we have 11. And those are like in simple layman's words. So let's go back to this specimen now. Yes. Excuse me, we need to back.